Emergency medicine is defined by split-second decisions made with incomplete information. When a patient arrives in distress, physicians must synthesize scattered symptoms, missing lab results, and messy history into a life-saving intervention. In 1863, Florence Nightingale established the baseline rule. The very first requirement of a hospital is that it should do the sick no harm. Standard large language models violate this rule by design. They optimize for fluent, plausible-sounding completions, prioritizing the continuity of the dialogue over the factual certainty of the medical record. Clinical charts are often a chaotic mix of contradictory vitals, pending labs, and unstructured physician notes. A standard AI will process this noise and output a definitive diagnosis, masking a deadly hallucination behind the authoritative tone of a professional summary. In healthcare, the primary engineering objective is an architecture that refuses to guess. We prioritize the system's ability to identify its own limitations over its ability to generate an answer. Agent 24, the healthcare intelligence agent, sits at the center of the regulated domain tier. The clinical environment presents a fundamental challenge. The AI never has direct access to the patient's true biological disease state. We model this as a partially observable Markov decision process. The true pathology is hidden. The system receives only noisy projections. As new clinical signals arrive, the agent maps that evidence onto a shifting probability curve. The agent generates a calibrated belief state, a probability distribution spread across competing diagnoses that explicitly quantifies its own uncertainty. Verifiability and graceful degradation must always supersede raw execution speed in this operational hierarchy. This schematic shows a 4-layer isolation pipeline. We enforce safety through rigid structural boundaries, hard-coded isolation that ensures compliance independently of the AI's creative engine. The data ingestion layer normalizes chaotic hospital records into a canonical format before any reasoning occurs. Using FHIR, the Fast Healthcare Interoperability Resources Standard, the agent transforms legacy HL7 messages and raw CSV files into a strict, validated JSON schema. The clinical knowledge layer is physically separated from the open internet to prevent free association. This dual memory architecture queries authoritative medical databases and attaches unalterable provenance metadata, the exact version and retrieval timestamp, to every fact used in a diagnosis. If clinical guidelines offer contradictory advice, the system flags the conflict. It presents the evidence basis for both options and defers the final decision to the clinician. Physically separating data normalization from vetted knowledge retrieval eliminates the foundational causes of AI hallucination. In Layer 3, the reasoning and decision engine performs the mathematical weighting of the gathered evidence. The agent executes a Bayesian belief update cycle. It multiplies prior epidemiological probabilities by the likelihood of the new clinical findings to continuously refine its candidate diagnoses. Raw probabilities generated by AI models are inherently overconfident and clinically untrustworthy. We correct this through Platt scaling and Brier score calibration. Calibration mathematically suppresses overconfident raw scores to ensure they match empirical real-world accuracy. If a calibrated system claims 80% certainty of pneumonia, it must be correct exactly 80% of the time. Mathematical calibration turns a statistical hunch into a reliable medical tool. To protect patients, the system requires a hard mechanical barrier against unverified outputs to function as a failsafe. The most important parameter in the agent's code is the 0.15 escalation threshold for critical conditions. We apply this strict monitoring to a defined list of high-risk cases: myocardial infarction, pulmonary embolism, sepsis, and stroke. If the system's confidence in its top diagnosis for any of these conditions falls below 15%, the agent halts the diagnostic process and pages a human. As we see in the diagnose method, the coordinator evaluates the scored differentials against the safety gate before any output is generated. The 0.15 number is the result of a cost asymmetry analysis. The expected cost of missing a fatal condition is roughly 10 times the cost of a false alarm. This threshold represents the calculated mathematical boundary of acceptable clinical risk. This allows the agent to monitor a 200-byte telemetry heartbeat from a patient at home, catching subtle physiological drifts before they escalate into an emergency. Ultimately, Agent 24's true artificial intelligence is most visible in the critical moments it actively chooses to stay silent. The final architecture stage is Layer 4, the explanation and delivery layer. Medical outputs require audience-aware design. A clinician needs complex SHAP attribution scores to trace the reasoning, while a patient requires a clear, plain language summary of their care plan. HIPAA regulations dictate the inclusion of an immutable audit trail. Every diagnostic trace, model version, and clinical guideline is cryptographically signed and stored in an append-only vault for a minimum of 7 years. The system uses a narrow, explicit feedback loop. Clinician overrides are logged to improve future knowledge retrieval, but they are structurally blocked from directly contaminating the core reasoning engine. Explainability and auditability are strict regulatory mandates required for real-world deployment. Agent 24 is a centralized node within a larger human hospital network. This technology is a clinical decision support tool. It is purposely designed to never act alone. If administrators attempt to remove the human clinician to automate diagnoses and cut costs, the entire safety architecture instantly collapses. High-stakes environments require real accountability and zero guessing. In our next episode, we will apply this same verifiable discipline to scientific research with Agent 25, the scientific discovery agent. In domains where being wrong costs lives, the most advanced AI is the one mathematically programmed to ask a human for help.